start with hypothyroidism. Hypothyroidism is a disorder characterized by inadequate thyroid hormone production and/or availability in peripheral target tissues. Hypothyroidism is a common disorder in the world, although the specific causes differ depending on geography. The most common cause overall is iodine deficiency, which is primarily encountered in the developing world due to the lack of sufficient dietary iodine. The same pathophysiology leads to an elevated risk of developing endemic goiter. In the developed world, the most common cause include autoimmune thyroiditis and iatrogenic hypothyroidism as a result of thyroidectomy or radioactive iodine treatment with insufficient thyroid hormone supplementation or replacement. With respect to the hypothalamic pituitary thyroid axis, the overwhelming majority of causes of hypothyroidism are primary, that is, the lack of thyroid hormone production is due to causes at the level of the thyroid. A small percentage of cases may be due to inadequate secretion of TSH from the pituitary or thyrotropin releasing hormone from the hypothalamus, which are referred to as secondary or tertiary hypothyroidism respectively. The symptoms and signs of hypothyroidism can range from mild to no symptoms to the classic presentation of cold intolerance, fatigue, puffiness and weight gain, dry skin, and hair loss. Myxedema represents an extreme of symptomatic hypothyroidism in which patients develop a constellation of severe findings such as an altered mental status or coma, hypothermia, bradycardia, and electrolyte abnormalities with an increased risk of cardiomegaly, pericardial effusion, and ascites, and myxedema typically occurs as a decompensation of chronic hypothyroidism due to an acute physiologic stressor such as trauma, infection, or an acute cardiovascular event. Thyroid function tests, and particularly thyroid stimulating hormone, are highly sensitive for screening for hypothyroidism. In adults, primary hypothyroidism is generally suspected when serum TSH levels are above 4.12 milli international unit per liter, although normal ranges differ depending on age as well as pregnancy. Further testing typically includes measurement of thyroid hormones, including free T4 and T3 levels. Elevated TSH levels with decreased free T4 and T3 levels are diagnostic of primary hypothyroidism. Elevated TSH levels with relatively normal levels of thyroid hormones are considered to be subclinical or mild hypothyroidism. Hypothyroidism is fortunately easily treatable with pharmacological agents such as levothyroxine LT4 or liothyronine LT3, which are synthetic versions of T4 and T3 respectively. LT4 is recommended as the first-line therapy in most patients for the treatment of hypothyroidism and is available in oral, intramuscular, and IV forms. The rationale for LT4 lies in the body's ability to convert the exogenously administered T4 into T3 by deiodinases in the peripheral tissues. Other therapeutic strategies include a combination of LT4 and LT3, LT3 alone, and desiccated thyroid extracts. All strategies were developed under the hypothesis that LT4 administration alone may be insufficient to replicate the normal euthyroid states, whether due to the inadequate in vivo conversion of T3 or the absence of some other heretofore undescribed molecules. None of these options is recommended currently as routine first-line therapy. Regarding combination LT3 and LT4 therapy, multiple randomized controlled trials have failed to demonstrate superiority over LT4 monotherapy in various outcomes, including achievement of target TSH and thyroid-specific symptoms and thyroid-specific health outcomes. Further research is needed to study the possible benefit of combination therapy in selected patients with low serum T3 levels or persistent symptoms on monotherapy. Both LT3 monotherapy and thyroid extract regimens have some preliminary supporting evidence on short-term outcomes and preference, but high-quality long-term data on safety and equivalent efficacy are lacking. Now, starting with the autoimmune thyroiditis. Autoimmune thyroiditis, as discussed before, is the most frequent cause of hypothyroidism in iodine-replete populations, that is, the Western populations. The most common type is chronic lymphocytic thyroiditis, otherwise known as Hashimoto's thyroiditis. This disorder is found predominantly in females at up to 10:1 female to male incidence ratio. In addition, there is a strong hereditary component with first-degree relatives of Hashimoto's patients having a 9-fold risk of also developing the disease. The etiology of Hashimoto thyroiditis is due to the presence of circulating autoantibodies to thyroid antigens, resulting in a chronic autoimmune destructive process involving the formation of immune complexes and complement in the basement membrane of follicular cells. This leads to the infiltration of lymphocytes into the thyroid follicles and eventually results in fibrosis, which decreases the effective number of follicles needed to produce thyroid hormones. The biochemical workup for Hashimoto's thyroiditis includes measurement of the thyroid function test as well as circulating thyroid autoantibodies, including thyroid peroxidase antibodies and thyroglobulin antibodies, which are present in 95% and 60% of the patients respectively. Euthyroid and subclinically hypothyroid patients with elevated autoantibody titers are at greater risk of progressing to overt hypothyroidism. In addition, thyroid autoantibody measurement is recommended in patients at higher risk of developing hypothyroidism, including those with other autoimmune diseases or taking drugs such as lithium or amiodarone. There is typically no role for imaging studies in the workup and diagnosis of Hashimoto's thyroiditis. However, patients with Hashimoto thyroiditis will frequently have symptoms of neck discomfort, pain, and globus sensation, necessitating neck ultrasound for diagnostic workup. Sonographic characteristics of Hashimoto thyroiditis include coarse, heterogeneous, and hypoechoic parenchymal ecotexture with increased vascularity, often with the presence of echogenic septae, producing a pseudonodular appearance that can be confusing with discrete thyroid nodules. The size of the thyroid may range from diffusely or focally enlarged to small and atrophic, and there may be mildly enlarged and more numerous parathyroidal lymph nodes from the autoimmune inflammatory process. Hashimoto thyroiditis has been associated with an increased risk of papillary thyroid cancer, but possibly with a slight improvement in prognosis based on the number of single institution surgical series. So any suspicious thyroid nodules or lymph nodes in the setting of Hashimoto thyroiditis should be appropriately worked up with the FNA biopsy. Cytologic features of Hashimoto thyroiditis include a moderately cellular specimen with aggregates of follicular cells with oncocytic or Hürthl cell changes, minimal colloid, and infiltration of mature lymphocytes. Giant cells, plasma cells, macrophages, histiocytes, and eosinophils also may be seen. Primary thyroid lymphoma, or rare thyroid malignancy with an annual incidence of 2 per 1 million, is associated with Hashimoto thyroiditis and can often be difficult to distinguish based on cytology due to similarities around having large number of lymphoid cells and lymphoid follicles with decreased colloid. The second most common type of autoimmune thyroiditis is postpartum thyroiditis, which can occur in up to 10% of the women within the first 2 to 12 months of the postpartum period. The pathogenesis of postpartum thyroiditis appears to have similarities and parallels to that of Hashimoto thyroiditis in that hypothyroidism may be preceded by a short thyrotoxic state. It is often associated with the presence of circulating thyroid peroxidase antibodies, and postpartum thyroiditis is associated with a tenfold risk of ultimately developing Hashimoto thyroiditis. Postpartum thyroiditis is typically short-lived with a resolution in 2 to 4 months. A short course of exogenous thyroid hormone supplementation or replacement may be necessary. The another one is subacute thyroiditis. It is also known as de Quervain's disease or subacute granulomatous thyroiditis. It is a relatively uncommon disease found primarily in the developed world. It has a female preponderance with a 2:1 female to male ratio and typically occurs in the 4th decade of life. The pathogenesis remains poorly understood, but the disease often occurs after a viral prodrome such as an upper respiratory tract infection. The hallmark of the clinical presentation for the de Quervain's thyroiditis is pain and swelling in the thyroid region, along with the low-grade fevers, dysphagia, and severe fatigue. Biochemical findings may include an elevated erythrocyte sedimentation rate, which is diagnostic. As with autoimmune thyroiditis, de Quervain's thyroiditis can be associated with transient hyperthyroidism followed by hypothyroidism. Cytopathologic characteristics from FNA biopsy include the presence of multinucleated giant cell granulomas. Histopathology shows evidence of granulomatous changes in the thyroid follicles. The follicles are enlarged with infiltration by mononuclear cells, neutrophils, and lymphocytes. The time course of de Quervain's thyroiditis is typically 2 to 5 months, and the vast majority of patients return to an euthyroid state spontaneously. Because of its self-limited course, no specific treatments are indicated except for symptomatic relief of pain and or temporary treatment of clinical hypothyroidism. The pain associated with de Quervain's thyroiditis can be treated with NSAIDs. More severe cases can be treated with a course of corticosteroids. Surgery is not typically indicated for treatment of de Quervain's thyroiditis, and reassurance and emotional counseling are often necessary, particularly during the painful phase of the disease.